Hello, my name is Connor Mackey, and today I'm going to be presenting my research on food as medicine in education, what makes a successful program. Before I get started, I would like to thank my faculty sponsor, Dr. Lisa Troy, as well as the Commonwealth Honors College. Over the last half-century, the U.S. has seen a dramatic decline in overall nutrition and health amongst its population. Metrics such as the doubling in the number of fast food restaurants since 1970 and obesity tripling in that same time already paint a scary picture, without mentioning the spike in other conditions such as heart disease, stroke, and diabetes. With this, a clear link between nutrition and health has been established, and efforts have been made to combat many of the chronic medical conditions that result from poor nutrition. Many have looked to medical professionals for guidance, and the healthcare industry has found itself woefully unprepared to support this change. Ultimately, the lack of nutrition knowledge amongst medical professionals can be attributed to an inadequate preparation in medical education. Our medical professionals recognize the importance of nutrition and related counseling, but lack the confidence and knowledge to adequately help and inform their patients. In the last decade, however, progress has been made to improve the state of nutrition in medical education. In 2012, Tulane University opened up the first teaching kitchen in a medical school, pioneering the newfound focus on nutrition. Since then, many other institutions have followed suit, creating programs and opening facilities to promote nutrition in their own curriculums. As this trend continues and more schools begin to adopt nutrition into their programs, I thought it would be important to explore what makes a successful food as medicine program, and the strategies schools looking to include food as medicine in their current programs can utilize to do so successfully. The best way to describe my research is through the process I took to conduct it. I began with the broad search for programs with some component of nutrition in their curriculum and a review of the available literature on these programs. I then utilized the Health Meets Food collaborative curriculum to find successful programs, along with their faculty, websites, and links to recent publications about them. With these publications, along with program descriptions and database articles on the programs, I created metrics to measure their success. I picked the 3 best medical schools and top independent program and analyzed them for common traits, methodologies, and practices that made them successful. I then employed PubMed and Web of Science databases with search terms including culinary medicine, food as medicine, and food as medicine program to find additional information. Overall, I looked at 4 programs: Tulane, the University of South Carolina Greenville, the University of South Carolina Columbia, and the Cultural Immersion Program for Health Professionals. It was found that each of these programs is effective in their goal of integrating food as medicine and nutrition education into a curriculum for the training of health professionals. While each model was unique, when assessing what made them successful, 4 main commonalities can be observed. All 4 programs had elements of experiential learning, coursework broken down into modules, inverted classroom models, and community partners. Each of these elements ultimately contributed to the success of all 4 programs. Practical elements and experiential learning can be a great way for students to learn how to act, communicate, and perform in real-world environments. It can teach students how to apply what they learn, resulting in better preparedness for their career. It also gives students the opportunity to fail in a safe environment, allowing them to hone their skills before having to put them to use in a professional workplace. Dividing coursework into modules also plays a large role in effective food as medicine programs. Most obviously, breaking up the coursework in this way allows for a clearer way to navigate the content, but it can also mitigate information loss and allow students to tailor their learning to best suit their interests. The inverted classroom model is another common element in successful food as medicine programs. This education strategy involves the reversal of the typical lecture then homework format, where the students complete most of their learning independently and the classes are used for practice and hands-on work. This provides more time for experiential learning in a food as medicine education. This is essential, as in the field, students need time to experience cooking and see firsthand the importance of the use of food as medicine. Additionally, this model yields significant improvements in learner performance and medical schools. The last of these 4 commonalities between the food as medicine programs that I examined in my study were community partnerships. Tulane partnered with the Refresh Project, a community health hub in New Orleans that connected students with additional partners such as Sprout NOLA, Liberty's Kitchen, and Topbox Foods. The University of South Carolina School of Medicine in Greenville saw a partnership with Prisma Health Upstate, a healthcare system, while USC School of Medicine Columbia partnered with a fresh food distribution program called FoodShare. As a result of their community partners, these 4 programs saw their students exposed to a variety of real-world situations. This ultimately contributed to their learning experience and helped them to make the program successful. In my research, I was able to find an abundance of information provided by schools about their programs, as well as from peer-reviewed resources. There was, however, a lack of long-term data to support the success of these programs. Additionally, the small sample size of programs explored is definitely something that needs to be considered when looking at the study. There was also an evident disconnect between programs themselves and how graduates utilize what they learn from these programs in their careers. This is a shortcoming that will need to be addressed in the future. After concluding my research, I have determined that a handful of medical schools and programs have already developed effective methods to include and encourage nutrition in medical education. While they are not perfect, these programs provide a model for what an effective program should look like. It is also important to note that current policy supports the need for these programs, but may need to be amended to aid schools in the development of these programs as they are rolled out around the country. In the future, more research will be needed to support this discussion. While data supporting the growth and recent successes of these food as medicine programs is abundant, there is a lack of information surrounding what graduates of these programs go on to do. Are they able to implement nutrition in their practices? Do they stay and support the community they called home? Does local culture play a role in their produce prescriptions? These are all things to consider as we move forward. Thank you.